Okay, good morning or good afternoon, depending on where you're logging in from today. And thanks so much for joining us. It's really a pleasure to be asked to present this information today. It's a topic that I've been working on for a number of years, and actually John Ellison has helped a lot with some of the development of this work in previous years in my collaborations with a couple of people that I'd like to acknowledge. Dr. Doug Keefe, who's an acoustical physicist and has a lot of interest in audiology and hearing, and he's at Boys Town National Research Hospital in Omaha, Nebraska, and is a frequent collaborator, and I really look to him for his expertise as he was one of the original developers of wideband reflectance and absorbance. And my other collaborator is Dr. Pat Feeney, who's at the university, or who's at the VA NCRAR in Portland, Oregon, and also at Oregon Health Sciences University. So we'll go ahead and move on from here. All right, so the topics that we're going to talk about are some of the principles of wideband reflectance and then absorbance, and I'll explain how those are related. Some of the terminology you'll come across, the instrumentation that's available through interacoustics, and some of the research background, and then finally clinical applications. So the roots of wideband immittance, as I was mentioning earlier, go back quite a ways. Originally, some of the development happened by John Allen in the 1980s, and then by Doug Keefe and colleagues in the 1990s. And application in clinical assessment of the middle ear has occurred over the past 2 decades. And this isn't unusual for an instrument like this to take quite a while to get into normal clinical practice. For example, it took at least 20 years for otoacoustic emissions to be used routinely in clinical practice. So a lot of that has to do with how well we are able to understand it as clinicians and interpret the results. The main advantage to wideband reflectance is that we can measure middle ear transfer up to 8 kilohertz, and this is really because of the improved calibration and the reflectance technique, which doesn't rely upon subtracting out the middle ear or the outer ear contribution. So the main advantage of wideband reflectance is that it's not as affected by the location of the probe in the ear canal. So it's a fairly simple principle. What we're doing is we're putting in a broadband signal, as shown by the blue arrow here. And in this case, the broadband signal is a click. And so it's very similar to transient evoked otoacoustic emissions and using a click stimulus. And then we're able to analyze frequency-specific middle ear transmission by looking at or examining the sound energy that's returned in the ear canal. So it's not that different from tympanometry or otoacoustic emissions in terms of how we are presenting the stimulus to the ear and then measuring the response returning. So in terms of reflectance, what happens is, so it's the reflected power compared to the incident power or the power we put into the ear. Absorbance is reflectance minus what's absorbed by the ear canal. So in the case of wideband absorbance, we're still looking at the stimulus going into the ear, and instead of what's being returned, we're examining the leftover part that has made it into the middle ear cavity. So in terms of wideband absorbance, we're examining the absorbed power compared to the power that was placed into the ear. And many studies have found that wideband absorbance is sensitive to a variety of different disorders, including middle ear effusion, ossicular disarticulation, eardrum perforation, ossicular fixation, eardrum atrophy, tympanosclerosis, conductive hearing loss, and structural ossicular abnormalities, as well as superior canal dehiscence. And I'll overview some of those different studies today, including increased intracranial pressure. The instrument that has been developed that allows us to make these measurements across a wide frequency range required that a new probe be developed, and the Interacoustics Titan also uses pressurized measures in addition to the newly developed probe. It also does traditional acoustic reflexes and pressurized transient evoked otoacoustic emissions, as well as distortion product OAEs. And then finally, if the if the system is set up in this manner, you can also do a screening ABR using the CE chirp stimulus. But today we'll be talking just about wideband tympanometry. So the Titan suite includes a handheld device. If you're using a handheld device, you can't actually save or make the measurements with wideband tympanometry, so it requires the whole suite where you would use the software in addition to just the handheld device. And what you get coming out is a 3D wideband tympanogram. Once you've done the click stimulus, you get a response in 3 dimensions. And I think this is one of the areas that's most difficult to understand because we're used to looking at tympanometry in 2 dimensions. So you can see the little blowout over here on the right side shows a tympanogram at 226 hertz. That's what we're accustomed to looking at. We can still get that information. That's coming from the very lowest frequency that's tested with the wideband tympanometry. And then over on the left side, the little blowout panel is showing wideband absorbance. And if you were to draw a line across the center of the screen, you would get the wideband absorbance across frequencies as compared to the wideband tympanogram, which is across pressure. So I'll explain a little bit more about both of those. So on the left we have absorbance, and on the right tympanometry in quotes because it's not the same as doing a single frequency tympanogram. We're actually extracting the tympanogram from the click stimulus. So to do that, we have the 3-dimensional tympanogram, and you can see here that we've got 2 lines drawn across, so we could actually extract a tympanogram at those individual frequencies. Or what we could do is we could actually average across it. So you can also get a wideband tympanogram that's averaged with the absorbance across a wide frequency range. In this case, it's from around 1,000 up to about 3,000 hertz, averaged over on the right side. And so that still looks like a tympanogram, but rather than seeing the admittance or compliance over on the left side, what we're seeing is the amount of absorbance into the ear canal. So this is analogous to what I showed earlier, where you put the click stimulus into the ear, and what's absorbed into the middle ear is the actual absorbance. In this case, you don't have to subtract out the ear canal admittance, because with absorbance and reflectance, we're simply looking at the amount of energy transferred into the middle ear compared to what we put in. And so we don't have to do a technique like we do with tympanometry, where we compensate or subtract out the ear canal contribution. This panel shows 2-dimensional tympanogram slices. So if you're trying to interpret wideband tympanometry, this is a really good place to start. So after you do your 3-dimensional graph, then you can go into a panel that allows you to look at the individual tympanograms. And now what it does is it turns it into an admittance, so that you can actually look at 226 and 1,000 like you're used to looking at tympanometry, and you can see what the admittance is over here on the left side. So the far left tympanogram at 226 is showing an admittance of around 0.8 milliliters, and then at 1,000 hertz it's showing an admittance of about 1.3 millimos. And then you also get an estimate of the resonant frequency. What this does is it examines the phase across frequencies, and it's able to measure the resonance frequency, which in this case is 849 hertz. Okay, so that's what the instrument does basically. What I'm going to explain now is some of the research background that goes into helping us to understand how to interpret the results that come out of the system. So this was a study that was done by Keefe and Simmons using an experimental system that preceded the Titan, but this is done using the same basic approach that's now programmed into the Titan system. So on the left we have average tympanograms from normal ears with normal hearing, and it's averaged across a large number of cases. And over on the right side we have an average tympanogram in ears that had a significant conductive hearing loss of 20 dB or greater, and you can see there are some notable differences in terms of the amount of absorbance across frequency. It's hard to appreciate that in the lowest frequencies, So where we would normally do a standard tympanogram at 226 hertz is far over on the left side. And you can see that that's a deep blue color for both the normals as well as the ears with conductive hearing loss. But as we go higher in frequency, there's a much larger difference between the normal and abnormal ears. And we have found this over and over again, that when it comes to detecting otitis media with diffusion, it affects a very large frequency range. So not just at 226 hertz, but the main range that it affects is between 1,000 and 4,000 hertz. So if you look at that frequency region, you can see that the normal ears have a lot of yellow and red, indicating very high absorbance on the scale. But the ear with a conductive hearing loss has absorbance closer to around 0.4 to 0.6. And so that difference is why one recommendation is to look at that average tympanogram from 1 to 4 kilohertz compared to the normal ranges. So if we do that, and that's shown here, we've got in blue the control group that had normal hearing, and you can see that there's very little difference in the low frequencies up until about 700 or 800 hertz, and then we start to see a very large difference between the different conductive hearing loss groups that had airborne gaps of 30 dB or greater, and the control group. And the largest differences happen between 2 to 4 kilohertz, where the wideband tympanometry is the most sensitive. And this has been replicated in other groups. These were in children that were old enough to be able to do complete pure tone audiometry, but it's also been done in infant studies, and I'll talk about some of those. This is a study that was done by Chris Sanford, who's done a lot of work in this area, and these are some cases of validated serous otitis media with diffusion, which is shown in the solid line, negative tympanometric peak pressure, negative TPP, which is shown in the dashed black line, and then an ear with a PE tube, which is shown with an X symbol over the dark line. In gray is the average normal response for wideband absorbance. And so what you can see for normal ears, starting at around 200 hertz and then going up to 800 hertz, is that we have this nice middle ear transfer where we get the most amount of transfer into the middle ear system between 1,000 and 4,000 hertz. And so that's why this range is more sensitive. This is where our ear is most responsive, and this is also where our hearing thresholds are the most sensitive. So it's really kind of the properties of the middle ear that allow our hearing to be most sensitive in this region. And so when we have a middle ear condition, this also tends to be a region that shows larger effects. And this is one of the reasons why it's very helpful to have a wideband middle ear response, as opposed to only looking at 226 or only looking at 1,000 hertz. Those frequencies were initially chosen because they're easy to calibrate, but we're not limited by that anymore by the new calibration procedures that are available with this system. So the ears with otitis media with diffusion show the lowest absorbance, and especially in that 1 to 3 kilohertz range, it's completely below the normal range. The ear with negative peak pressure is a little bit lower, but not as dramatically low as the ear with otitis media with diffusion. But the ear with a PE tube acts completely differently. We have normal absorbance through the high frequency range, and then we've got abnormally high absorbance in the very low frequency ranges. And so these big undulating peaks are very common with open and patent PE tubes or an eardrum perforation. So getting a sense of what these patterns look like is really helpful if you're trying to interpret results as an audiologist. And the Titan has some pictures that they provide to you of different types of pathologies, but I would just take those as a general indication. You can't use that specifically to diagnose a particular pathology. It's meant to just aid you in interpretation. What can really help is if you compare the results to the air bone gap. So here are three different types of pathologies. We've got stapes fixation, otherwise known as otosclerosis. We have superior canal dehiscence, that's shown in green, and then we have an ossicular discontinuity shown in blue. And so what we have graphed here are individual ears, and this is from a study by Heidi Nakajima. And what we see is the absorbance level over on the left relative to normal absorbance. And so this is an experimental study before and after these types of manipulations in temporal bones. And so compared to the baseline absorbance, you can see that ears with superior canal dehiscence generally have an increase in absorbance, similar to the increase that we see with ears that have discontinuity in blue. The difference being that the superior canal dehiscence doesn't cause a significant shift in the air-bone gap, whereas an ossicular discontinuity shows a huge change in the air-bone gap. So if we have increased absorbance, it's very helpful to examine the air-bone gap to get a sense of whether this is a problem that is more likely due to something like a third window effect as opposed to an ossicular discontinuity. Conversely, the stapes fixation also shows a large increase in the air-bone gap, but it shows a decrease in the absorbance level. And it is quite variable, but you can see that most of the ears have significantly lower absorbance compared to the ears with discontinuity. Naveed Shanaz has done some interesting work looking at the effects of otosclerosis, and this shows normal hearing ears that are below the 95th percentile in the normal range, which is in gray, and then above the 95th percentile in dark gray. And so we have 4 otosclerotic ears, so individual ears, and you can see that the primary abnormality that we see is in the region of 1,000 hertz and below. So if you're trying to distinguish abnormalities that are due to primarily a stiffening disorder like otosclerosis, you're going to mainly see effects below 1,000 hertz, whereas as I showed earlier with otitis media with effusion, the effects are decreased absorbance from 1 to 3 kilohertz. So this, having these types of frameworks in mind can help you to start to distinguish between air-bone gaps that are due to ossicular fixation as opposed to otitis media with effusion or due to eardrum perforation or ossicular disarticulations. Another very important application of wideband absorbance has been in evaluating newborns. So when newborns are screened, they often do not pass otoacoustic emissions, especially on the first day of life. And that's because there's retained amniotic fluid in the middle ear often. And in children who were in the NICU who are at higher risk for sensory neural hearing loss, we also see these middle ear problems. And often it's due to retained mesenchymal tissue that might be in the middle ear after premature birth. So these middle ear problems look a lot like otitis media with effusion when you look at wideband absorbance. It's a different problem because it's present from birth, so it's not an infectious process, but still it's tissue in the middle ear that's causing a decrease in middle ear transmission. So when we look at newborns on the first day from the study by Chris Sanford, what we can see is that the ears that did not pass on their DPOAEs, which are shown in dark gray, have much lower absorbance, especially in that 1 to 4 kilohertz range that we've seen for otitis media with effusion. So it's really acting like OME, even though it's a different condition at birth. And you can see that the ears that passed have much higher absorbance, so that would be the normative range. And again, it's really best in terms of sensitivity in the 1 to 4 kilohertz range. The traditional frequencies that we use down around 226 or at 1,000 hertz don't show the large differences, so they're not as sensitive as these higher frequency ranges. On the second day, there's a small number of ears here on refer, but you can see they're still lower, but they're starting to improve. So this is an indication that what we're looking at is a temporary problem in these ears as opposed to a permanent hearing loss. And so combining wideband absorbance with your follow-up ABR or OAE testing can assist you in knowing if you've got a middle ear transmission problem happening. This was a study that I did that was very similar to the study that Chris Sanford did. And so it's nice to compare across different studies. Lots of different groups have found very similar effects. So we've got good replicability across many different studies. So this was a totally different sample. And what we have is reflectance rather than wideband absorbance. So this is simply, think of it as upside down, because reflectance is 1 minus absorbance and vice versa. So it's really easy to make that conversion. So in this situation, higher reflectance is abnormal, and that's shown in red. So those are ears that didn't pass their DPOAEs. The ears that did pass are shown in green. And then we have an overlap region in yellow that are for mildly abnormal reflectance. And so we have an individual result shown in the black line. And with that black line, what we can see is that this is an ear that is completely in the pass region for wideband reflectance, and it's an ear that passed on DPOAEs. On the right side, we have an ear that referred on DPOAEs, but it looks like we have a mild middle ear problem because this ear is showing reflectance that's in the middle range, which is more of an ambiguous region. If it was completely in the red, that would be very clear that we've got a middle ear condition, but in this case, we have a mild middle ear problem that's causing increased reflectance. Again, I just want to point out, not to be a broken record, but the main region that's most important here is the 1 to 4 kilohertz region. And so in this same study, we looked at changes in wideband reflectance with age. And what you can see here is that for ears that passed, the wideband reflectance was around 40% on average across the whole age range from 13 to 60 hours. But if we looked at the ears that referred on DPOAEs, their reflectance was closer to 70% initially, and then it gradually improved. And so by the time they were 60 hours old, the ears that had referred were very close to the pass ears, showing an improvement in middle ear status with age in the newborns. So if we look at test performance, over here on the left, we have at the top all of the ears that referred on DPOAEs, 131 ears, and then all of the ears that passed, 265 ears. And what you can see is that there is some overlap. So we have some DPOAE refers that had normal reflectance, but most of them had abnormal reflectance. And then down at the bottom, you can see that there are some ears that passed that had abnormal reflectance, but most of them were in the normal range. So while there's a little bit of overlap, the two samples were quite distinct. And so if we look at that in terms of a test performance type of analysis, what we can see is that the hit rate reaches around 80 to 90% with a pretty low false alarm rate. And so we've got 80 to 90% sensitivity with a false alarm rate of around 20 to 30%, which is pretty good. So this is in the newborn period, and that's for reflectance at around 2 kilohertz. Reflectance at 1 kilohertz didn't perform quite as well. That's the light gray line. But compared to 1 kilohertz tympanometry, reflectance performed much better. So 1 kilohertz tympanometry shows that we have lower sensitivity and a higher false alarm rate compared to the 2 kilohertz reflectance. So this is in the newborn period where we think that reflectance is really both more sensitive and more specific than standard tympanometry. And so we're encouraging it to be used for diagnostic assessments after newborn screening. And that just shows the number of ears. So since then, I've done some more studies assessing babies longitudinally. And these are normal babies that were born in the normal newborn nursery, as well as babies that were born in the NICU. And this was published recently in Hearing Research. And what we can see is that there's some development of absorbance going on. So I'm going to go back to absorbance again. So here, higher is better. Absorbance on the left side from 0 to 1.0. And what you can see is that at birth, which is 0 months, we have a pretty flat absorbance curve. That's in blue all the way across. And then we also looked at the phase, which is known as group delay. And so ambient means that this is without any pressurization in the ear. So at ambient pressure, we have a fairly flat absorbance curve. And the group delay shows that we have less of a group delay in the lower frequencies at birth, and then it flattens out at higher frequencies. So the ear is more mass loaded in the newborn period and at 1 month of age, and that's because the outer ear canal is more flaccid. So we see the most development happening in the low frequencies for both absorbance as well as group delay. So for absorbance, what happens is we have actually a decrease in the low frequencies with age. So by the time the babies are 6 months of age, we see a more adult-like pattern happening where you have lower absorbance in the low frequencies, and then it reaches that peak in the mid-frequency range like we expect to see, where the middle ear is best at transferring energy. So 6, 9, and 12 months didn't really change, but that period from birth to 6 months of age, we see a lot of developmental changes. However, if we're using the frequency range from 1 to 4 kilohertz, the differences between the age groups are really pretty small. So this is just further validation of the fact that most of the developmental changes are happening in the low frequencies. So that's at ambient pressure. If we examine it at tympanometric peak pressure, the curves are really quite similar. So you can see at tympanometric peak pressure for the newborns and the 1 month olds, we see most of the developmental effects happening in the low frequency range. And that's also true over here for group delay, although once you pressurize, the group delay looks a little bit different than it does at ambient pressure. And so this is a circle showing that's where most of the developmental change is happening in the low frequencies. So in the same group or the same study, we looked at babies that had passed and referred on newborn screening, as well as passing and referring on the 2-stage screening, which included ABR. So at the time of birth, we have a 2-stage pass and refer, a really large number of ears passed, 277, compared to 86 that referred. And you can see a really nice replication of the earlier studies by Chris Sanford and myself, showing that the wideband absorbance is much higher in the high frequency region for babies that passed. At 1 month of age, the differences aren't quite as big, but we still see that that 1 to 4 kilohertz region is the most diagnostic. And then at 6 months of age and 9 months, you can see there are small differences. As it becomes more adult-like, we're really not seeing much of a difference at all in the low frequencies, but this frequency region from 1 to 4 kilohertz remains highly diagnostic at each age range over the first year. So this is the first study that has tracked the same infants over time. And so we really feel confident that, you know, over the first year, and then combined with the earlier studies that Doug Keefe did, that this is a tool that can be used across a wide age range with good sensitivity. So one question is, what about children that are more difficult to test, where you really have a lot of difficulty getting good behavioral audiometry? So we studied a group of children with Down syndrome, and of course children with Down syndrome can be quite challenging to test behaviorally, and they have a very high incidence of middle ear problems. So we wanted to see if wideband absorbance was a good tool to use in this population. So we had 34 children with Down syndrome. The mean age was 6 years, and 16 of them had normal hearing, 28 had conductive hearing loss, and 18 had tubes present. And you can see the age ranges were a little bit different in each of those groups. And then we had 49 typically developing children, TD children, had normal hearing in most cases for 48 of them, 19 had conductive loss, and 30 had tubes. So we did have some age differences just in the sample we were able to obtain. And we had to exclude 2 that had sensorineural hearing loss and 2 that had mixed hearing loss from the Down syndrome group. And this was published recently in the International Journal of Audiology. So this is a graph that shows the hearing thresholds in children with Down syndrome, which is abbreviated DS, and then typically developing children, which is abbreviated TD. And so the typically developing children are shown with the filled symbols, and the children with Down syndrome are shown with the open symbols. So the ones that had normal hearing, both the TD and the DS groups, you can see the normal hearing status down here at the bottom. And then the typically developing children with tubes also had normal hearing. However, the children with Down syndrome who had tubes present still had hearing loss. And this is frequently reported in Down syndrome because the middle ear space is much smaller and they seem to have more long-standing middle ear problems. And then we have kids with, typically developing kids with conductive loss had the worst hearing, and then children with Down syndrome who had conductive loss are also shown. They actually overlapped with the ones that had tubes, so we didn't really show a big improvement in children with Down syndrome with tubes. And so that's a reason why we need to be able to evaluate them after they've had tube surgery. Standard tympanometry is shown here for the children with Down syndrome and the typically developing children. So the equivalent volume, of course, is much larger with a PE tube, although the children with Down syndrome tended to have smaller equivalent volumes than the typically developing kids. And then you can see the equivalent volume for conductive hearing loss and normal hearing children. This is just to validate the fact that these children actually did have patent PE tubes. All right, this is an individual recording from a 64-month-old boy with Down syndrome who had normal hearing and normal DPOAEs. And you can see this 3-dimensional graph shows in that mid to high frequency region lots of yellow and red, showing that we've got good absorbance in this range. This is the phase plot over on the right side. I'm not going to spend a lot of time on phase today because it's more difficult to interpret. But down in the bottom, what I'd like to show you is the average tympanogram. So we've got the low frequency average tympanogram down on the bottom left and the high frequency average tympanogram here on the right. This low pass tympanogram is analogous to what is measured on the Titan that I showed earlier, that average across the low frequency region. And then in the far right, we have the absorbance plot. So in gray, we have normal absorbance compared to this ear at ambient pressure, at TPP, and then at the positive part of the tympanogram and the negative part of the tympanogram. And what I want to draw your attention to is the difference between the ambient pressure and the TPP tympanogram. So this ear had some negative pressure, even though it was a normal hearing ear. We can see that we get better absorbance at TPP than we do at ambient. So comparing those two will help you to see whether you've got an effect due to negative pressure. This then is a little girl, 35-month-old girl with Down syndrome who was diagnosed with OME and had a conductive hearing loss. And what you can see is that her tympanogram is shifted to higher frequencies. So in comparison to the boy that I showed previously, she has much lower absorbance in the mid-frequency range, and her average tympanogram is nearly flat for both the low and the high frequencies. And then if you look at her ambient and TPP recordings, we have very low absorbance, especially for the TPP recording in the mid-frequency range. And then her phase plot is quite broken up and irregular, and we often see that with an otitis media with effusion case because the phase angles are distorted as the signal is being transferred at different frequency regions. We don't see the nice smooth phase plot with a clear crossover for resonance like we do in a normal ear. It's a bit more broken up. And then finally, I wanted to show you an individual case of an ear with a PE tube. So this is a child with Down syndrome and a patent PE tube. And what we have are very high resonant peaks in the three-dimensional tympanogram. So this is very similar to what Chris Sanford showed in the study that I showed earlier. And we saw this in all of the ears with patent PE tubes. Virtually every one of them had these very high undulating peaks. And so that can be a helpful sign to look for in terms of a patent PE tube or perforation. And then as you would expect, there's a flat tympanogram. You also get a volume measurement, and so the volume measurement would be higher as well. So you can use the typical indicators that you use from standard tympanometry, but in addition, you can look at this at higher frequency regions. And then you can see over here those high undulating peaks that are very sharp due to the patent PE tube, and no difference between ambient and TPP because we've got an open middle ear space. So those are the kinds of patterns on an individual basis that you would see. But when it comes to looking at averaged across groups, you can get some really interesting information. So in the typically developing children, we see the normal hearing children have the curve in green, which is a normal type of adult-like curve. The children with Down syndrome who have normal hearing, shown in green, also have that nice, smoothly increasing curve with best absorbance in the mid-frequency range, whereas the children with conductive loss have much lower absorbance for both the TD and the Down syndrome groups. So even though children with Down syndrome have much smaller ears and are more difficult to test, we were able to show very similar results with wideband absorbance in this very challenging group, showing that it is a very effective test for that particular problem. The children with tubes have very high absorbance in the low frequencies. So that's the pattern that was reported by Chris Sanford and by other studies. And we see that both in the typically developing kids and in the children with Down syndrome. But what's really interesting is in the children with Down syndrome and tubes, their absorbance in the higher frequencies is much lower compared to the typically developing children. And this may be the reason why we're still seeing hearing loss despite having tubes present, because the middle ear space still has some abnormal tissue present. And this may be the root reason for the continued hearing loss despite the presence of PE tubes. So we got some diagnostic information in the higher frequencies in the presence of tubes that was useful. And this is just a summary of that, what I really just said, and so that helps to validate wideband absorbance as a clinical tool in children with Down syndrome. I have a couple of case studies I wanted to show you. This is one that was provided by Naveed Shanaz in an adult ear that had otosclerosis. And you can see the very large conductive loss on the right side compared to the left side. And if we look at the 3D tympanometry, you can see very large differences between the more normal left ear, which has a sensory neural notch, and the abnormal right ear that has a very large conductive hearing loss. And that was across a really broad frequency range. We can see that difference. When we look at the individual tympanograms, so in the more normal left ear, you see a peak in the 226 and 1000 hertz tympanogram, as well as the frequency average tympanogram. But when we look at the individual recordings for the right ear, we have much lower admittance, both at 226 and at 1000 hertz. And then the frequency average tympanogram really shows that notable difference in this ear with otosclerosis. And here's that same ear looking at the absorbance in the more normal left ear. There's a little bit of a decrease in the high frequencies, and it may be that there is some otosclerosis starting in that ear, even though there's not a significant conductive loss. But in the right ear, we have very low absorbance across a really broad frequency range. This is an adult case with dysarticulation, and what I want to point out here is that you can see really high absorbance in the low frequency region. And then what we have is a sharp drop-off. So this is like a mass loading effect, where the very high frequencies are mass loaded by the disarticulation. And so that's a really notable pattern that you can see because of the ossicular disarticulation. And it's quite different from the PE tube case where we have very high undulating peaks. In this situation, we've got high absorbance in the low frequencies and then the drop-off in the high frequencies. And then this is a case, so to kind of echo that, this is a perforation plus a disarticulation. And in this case, the perforation really runs the show. So we see those high undulating peaks because of the open middle ear space. So it would be, unless you knew, it would be really hard to diagnose a disarticulation from this, but you can definitely see because of the high equivalent volume, the flat tympanogram, and then these high undulating peaks in absorbance. This is very much like what I showed in a child with Down syndrome who had the eardrum perforation with these high undulating peaks. Okay, and then finally I wanted to show you some cases from babies that were in the study, individual babies that we tested both at birth and then we followed them up later. This is a baby that was cared for in the NICU, so had some risk factors for hearing loss. And what we can see in the DPOAE levels is we have a nice large DPOAE across frequencies for both level and signal to noise ratio. What's shown in gray is the normal range with our cutoff criteria in the dotted line, so well above the cutoff criteria for both level and signal to noise ratio. And if we look at the absorbance, you can see this infant has very good absorbance, actually a bit above the normal range across the whole frequency range. So that goes along with the normal diagnostic ABR and also normal visual response audiometry that was tested later on. In comparison, this is a baby who was in the well baby nursery with no risk factors who passed newborn hearing screening. And in this case, when they came back for follow-up, we had a lower than normal DPOAE for both level and for SNR at some frequencies. And that was unexpected. So we went ahead and did a diagnostic ABR, which showed borderline normal results. And we can see that the absorbance was low. So although this baby had passed newborn screening, when they came back later in our longitudinal study, they had developed otitis media with effusion. So we were able to pick that up with the absorbance. And then when we followed them up later after treatment, their visual response audiometry was normal. So that is really helpful to be able to see that and follow up, that you can use the wideband absorbance test as a cross-reference. Otherwise, we would have been confused by the fact that the ABR was not normal. And then finally, I have a case of an infant from the NICU who also had some risk factors with premature birth and gentamicin exposure and referred on newborn hearing screening. And this infant showed a DPOAE level that was actually pretty high, but the signal to noise ratio was quite low. So didn't pass on signal to noise ratio. The diagnostic ABR showed a moderate mixed hearing loss, and so did the VRA. And what we can see is that the wideband absorbance was high in the low frequencies, but very low in the mid frequencies. So this indicates a middle ear transmission problem that was a nice cross-reference with the ABR and the VRA. So this is a graph that can kind of help us to compare the use of wideband tympanometry as well as reflexes and otoacoustic emissions for different types of pathologies. And I'm not going to spend a lot of time going over this because it's pretty straightforward, but it's just a way to help think about wideband tympanometry and how it can fit into the diagnostic test battery. And so in terms of take-home messages, I like to tell people that we should really move beyond the ABCs of immittance, just classifying standard tympanometry in terms of a type A or type B pattern, and really look at higher frequency regions. The nice thing about wideband tympanometry is it's quite familiar in terms of the probe and the measurement system, but the stimulus and recording is different. So we're using a wideband click rather than a pure tone. And we're signal averaging it. So one really powerful addition is that we provide a series of clicks that are averaged to extract them from the noise. And we also have more normative data for wideband reflectance across many different groups than we really have for single frequency tympanometry, like 1,000 hertz tympanometry. So we have developed quite a number of studies across many different groups, and so that really helps us to be able to compare. And I didn't show these data today, but there are a number of studies looking at test-retest reliability, and it's quite high for wideband absorbance in the high frequency region. And the clinical studies that are available have shown better test performance than single frequency tympanometry, at least in the newborn period. I wanted to provide you with a couple of sources of more information if you want to read some articles. There's an ear and hearing supplement that was supported by the Eriksholm workshop from the Otakon Foundation. And there are a number of different studies from many of the authors that I have mentioned today. And then there's a textbook that Naveed Shanaz and I wrote that has a lot of the basics and interpretation information, both for acoustic immittance, pure tone measures, as well as wideband measures. And then I wanted to pause here and take questions. So thank you all very much for your attention and sending any questions in that you have. Okay, there was a question, should clinicians be aiming to carry out wideband absorbance at peak pressure rather than at ambient? So what we're recommending is a pressurized measure, because I showed quite a few examples where comparing the ambient to peak pressure method showed quite a bit of difference across a frequency range. And so if it was only done at ambient, it's difficult to distinguish a condition like otosclerosis, which would decrease the absorbance in that low frequency range, from simply negative pressure. So negative pressure and decreased absorbance due to otosclerosis can show a similar pattern under an ambient pressure condition. But then if you pressurize it and look at the tympanometric peak pressure, the ear with negative pressure would show an improvement. So the ear with otosclerosis, assuming that it doesn't also have negative pressure, would show a similar result. So that's one rationale for being able to compare ambient and peak pressure results. We have a question, have we had difficulty educating physicians on wideband absorbance? And if so, any tips on overcoming the barrier? I think that the difficulty I've seen with physicians is not too different from some of the barriers that audiologists feel when they're doing any type of new test like this. I think physicians are used to us interpreting tympanograms in the ABC type of pattern, and that's the way that they were trained. So I think overcoming that by showing some printouts from ears with different types of pathologies can be really helpful. So as I was saying earlier, you can't really use the patterns that are shown at the bottom of the Titan as black and white. You know, it's not that every ear with otosclerosis is going to look like that pattern, but if you can show some of those patterns to physicians and help them understand that this is simply across a frequency region as opposed to across pressure, and show the actual graphs, I think that most people are very visually driven, and so showing those visual patterns coupled with the pathologies, and then some of these case studies that show the audiometric information combined with the visual pattern can be useful. And then too, doing it on yourselves. I think, you know, trying it out on yourself, looking at the response across frequency regions compared to some of the different patterns can be helpful. One other thing that I would say is some people worry about this taking additional time, but essentially what you're doing is you are substituting a different stimulus. So the main time involved is in learning the new instrument and then learning to interpret it, but actually doing the test doesn't take any longer than doing a standard tympanogram. It's just that you get a lot more detailed information out of it. So I think that can help overcome the barrier as well. And then if you are worried about purchasing new equipment, what can help is, you know, in thinking about replacing old immittance equipment, you know, upgrading to a new piece of equipment that might include other tests like otoacoustic emissions, can be really helpful because you're looking at a whole suite of equipment as opposed to just replacing tympanometry. And I think that can help in terms of any financial barrier. Dave Spidel said you'll often see fairly large dips in the higher frequencies on normals. Are these simple resonant frequency dips and patterns? Some audiologists have a tough time when the graphics aren't always within the normal region. I really agree with this. I think that part of the problem is in translating from averaged data across many individuals to a single person. So I think I'll actually go. All right, so here's a good example. If you look at this graph, we've got averaged across a large number of cases in gray, and then what we have are some individual cases that are abnormal cases. And so what we see are some large undulating peaks, like with the perforation, but if it occurs across a fairly broad frequency range, as is shown here for the ear with a perforation, as well as the ear with negative tympanometric peak pressure, then it's more believable. So if you just see a change in a small frequency region, that can be quite normal in an individual ear. So we're really looking for patterns across a broader frequency region than just a small one that might happen with certain peaks. Okay, well, again, thank you everyone for listening today, and it was really a pleasure presenting.